Hello. I am both delighted and honored tonight to introduce to you Dr. Paul Remiliotis. If you looked at the announcement that went around for this lecture, Dr. Paul Remiliotis is the founder and former director of one of the busiest university hospital clinics in North America, and an assistant professor of pediatrics, former director of multi-format health communications at McGill University. He currently serves as the medical officer of health and Chief Executive Officer of the Eastern Ontario Health Unit. He's the first online pediatrician in the world, and he has earned a reputation as a down-to-earth communicator who produces state-of-the-art educational health resources, which are trustworthy, accessible, and informative. He uses his expertise from years in, guess what, professional music recording and broadcast industry. And he has oriented his career towards development of multi-format health communication programs for varied global audiences. He has worked with many evolving technologies, from the analog and pre-internet era of the 1970s to today's instant wireless mobile and digital platforms. As a public health leader, he has applied his health communications experience to the delivery of public health information and content. His vision is consistent with the reality that education and communication are essential tools in public health practice and knowledge exchange. As a medical officer of health for the Eastern Ontario unit, he created and now oversees a full in-house communication team and studio. This is one of very few health units in North America that have an in-house media production studio like that. This unique setup provides public health communications programs for local, provincial, and national use. If you just want to get a sense of how he approaches this communication, the Eastern Ontario Health Unit Multimedia Resource Center webpage, which is accessible to anybody, contains a welcome message from him where he says, today's technology-savvy public is plugged in to content on demand, converging media formats, and evolving social media. These trends present an unprecedented opportunity to reach even more people with entertaining, pertinent, and practical public health educational resources. We are committed to taking full advantage of this cost-effective and environmentally friendly way of delivering health information content to as many people as possible. Our vision is to help lead the way towards an informed and therefore healthier community. So as you can see, he's a bit of a trendsetter, even though he's been working as a physician, a pediatrician, and one of the healthcare leaders in this region. He also serves as the associate faculty member at the Johns Hopkins University at Bloomberg School of Public Health. So he has these multiple hats. He's been doing communication work, as noted in his bio, since the 1970s, but he still manages to stay on top of the current trends, not only in media technology, but also how people consume media content. Tonight, he will discuss social marketing strategies, considerations of audience characteristics, and the use of persuasive communication theories when applying emergent technologies to health practice. So I'll ask you to join me in welcoming Dr. Paul to our class tonight, and we'll save Q&A for the end. Thank you.
Thank you very much. Thank you very much. It's my pleasure to be here tonight. I've been looking forward to this. I met Irina back in May, I think it was, and I'm very happy that she invited me to come here to talk to you tonight. I was telling Irene that I give a lot of talks, and most of them are related to public health, and in terms of some of the work that we do, and flu epidemics and all these things that affect the public health domain. And then on and off, I'm invited to give a talk on health communication. So I look forward to that, because that's what I really love to do. I mean, it's not that I don't love medicine, but health communications really stems from my heart. It's actually something that I grew up with. I started playing as a professional musician when I was 14. I started producing records, selling records worldwide for many years, and that paid my way through medical school. And then that's why I do both. So people ask me very often, how did you end up doing communications in health? Well, that's how I ended up doing it. So, and sort of my zeal for health, actually my zeal for communications and the implementation of communications technologies into health led me to the current position that I have, which is leading the public health efforts in Eastern Ontario. Because I believe that public health, population health, is really an opportunity for us to embed health technology, educational technologies, and not only embed them, but also try to lead the way and try to catch up with what's changing. So today, what I'm going to do is I'm going to give you an overall outline of setting the stage. I'll give you sort of a historical perspective of the evolution of health and health and communication sort of intersections. I'll talk to you a bit of the technological aspects of media evolution. I'm going to talk, and I'll spend some time on audience characteristics and persuasion theories, which are actually very important. Social marketing, I'll give you a bit of a overview of social marketing, how to approach social marketing, using a lot of the theory and a lot of the practical aspects that we've learned along the way. Then I'll give you a bit of examples of some of the practical aspects and an approach that I've created in terms of sort of a simpler way of approaching how to create a social media, a social program, or an educational program. And I realize that this course is part of the communications, your third-year communication students, most of you, and I know that this is an advertising course, and a lot of what I'm going to talk about touches on many aspects of those things. And when you focus in on social marketing, you'll see that there are a lot of lessons learned from non-health disciplines, science disciplines, psychological science disciplines, anthropology. So this is what I like about all this convergence of health into communications, and then looking at the study of communications and trying to understand the processes, the evolutions, and how they can emerge together into being able to help us actually become better healthcare providers, but also providing the public with messages that make sense and content that makes sense. So public health, what do we do in public health? People want to make the distinction. They ask me all the time, what is public health? Well, public health essentially is why we're all healthy. Public health is not really a one-on-one. It is a population health approach where we look at health protection and health promotion across Ontario, across Canada for that matter, and where we deliver services to the population. So what does that mean? Well, the water that you drink, we ensure that it's safe. The restaurants that you eat at, including the one here, we inspect to ensure that the food is safe. The vaccinations that are delivered to your families, to your kids, to your uncles and cousins and nieces, we are the ones that deliver them. So essentially, it's health protection and health promotion, and very, very fertile ground for implementing communications and technology, especially with health promotion and prevention. And we know, and I'll just give a little small plug to why prevention is important. I just gave a talk last week to a bunch of lawyers and legal aid and financial advisors, and looking at why we prevent and how cost-effective prevention is today. An ounce of prevention is worth a pound of cure, and essentially we do know if you prevent disease today or support proper development and so on, you'll save a lot of money down the line. Also, and we do know that areas where there is poor health, it equates to increased hospitalization use, decreased life expectancy. So health promotion and health protection actually prolong lives and ensure that the lives are well. And our goal in public health is to work together collectively with community partners, and you'll see later on with some of the examples that I give you, community partners together working collectively to ensure the health and wellness of the population that we serve. So in a nutshell, that's what public health is. And so the background in terms of how I envision public health, how I envision the challenges that are facing us is that early on in life, we realized, life of health, early on we realized that healthcare is changing. As you'll notice over the last couple of years, all these reports have come out. We can't afford health, we can't afford acute care, we're looking at ways to save money, we're worried about aging baby boomers and so on. So the healthcare face has changed from what it was 20, 30 years ago, even 10 years ago. There's also the evolution of health partnerships. So we work a lot with agencies. We work with the concept of multidisciplinary teams. And there's an opportunity as well to communicate and share knowledge and share content with everybody. That's another different approach. Health partnerships as compared to the one-on-one doctor-patient relationship, which was classic back in the 50s and 60s. And we also need to train communicators. And I actually, this slide I wrote in 1990. that you're seeing here. And a lot of it hasn't changed because we needed to train communicators because we recognized at that time, 90s was the time where you had the digital era starting, 95, internet and so on. And that's the time where we recognized that there would need to be communicators among healthcare practitioners. And not only, when I talk about communications, as you'll see, I have a broad spectrum of communications. I don't just talk about technology. I talk about actual communication. And I'll show you later on some examples. And obviously technological advancements in communications. Back then it was actually Yahoo didn't exist, Google didn't exist, and we had Netscape as our browser. And it was a 28.8 modem. A lot of you probably never heard of that stuff. But that's, we started with that. But when we started with going from, audio tapes to digital to hard drives, and a lot of you don't even know who knows what the first non-linear digital video editor was called? The Amiga toaster. Look it up. Then Avid came out, and then Adobe Premiere came out, and so on. So those are the things that we were faced with, and they were quickly evolving and emerging and blending with each other. So that was one of the challenges that we had. So let's go to the next one here. So today's reality really is, digital and social media has changed the way health information is exchanged, and that's happening all the time. What was relevant a year ago may be irrelevant this year, or something else came over. All these social media evolvements and so on, and because of the presence of savvy population that wants consumers and patients, whatever you want to call them, they want to be empowered. They're looking at social media, they're looking at online sources to be empowered. And the other thing too is they demand information that influences their behaviors and outcomes, and that's where our opportunity comes. We have an opportunity right here to be able to provide them the information that hopefully allows them to make the proper decisions for their own health and wellness and that of their family, because it's important. So let me spend a bit of time talking about some of the technological advances. And I know a lot of you, it's just going to be boring for you, but I'm just going to go quickly just to show you, again, some of the changing patterns and challenges that we've had as we evolve to today. So essentially, using new media technologies for dissemination of public health today has become essential, so we can connect and communicate with today, and as I said on my website, today's tech-savvy and perpetually connected audiences. They want it now, they want it right away, and that's what we're dealing with. So we need to be able to catch up with that. No longer can you publish something in the newspaper. No longer can you say, well, we'll do an ad on the radio. You have to sort of adapt to the changing behaviors. And again, this is a slide that I wrote, and I purposely left it there because it looks archaic, I know. And this is a slide that I created back in the early 90s that I describe it as the health communications wheel. Essentially, the content is in the middle, and you had all these different ways of disseminating information. And so, lectures, slide projectors, books, audio cassettes, CD came out back in the late 80s. Satellites there because there was satellite transmission of a lot of health education materials we used to do back from McGill. Computers started coming out, fax machines, and so they represent, I call it the wheels, and those spokes of the wheel change and interchange and interlock with each other very often. So you give them a bit of a more modern tinge to it right now, where you kind of look at all the new USB keys, but you know what's still in there? This is still in there, and I'll talk a bit about that later. The one-on-one interactions in there, we shouldn't get lost. We shouldn't get lost, and that's the message I give to a lot of new medical students and residents. Yes, we have technology. Yes, we have ability to communicate 24/7, mobile, and so on. But don't forget that there's also that one-on-one communication. So that's still there, and that's important depending on the context. So that's a challenge to us, and it's changed. And so, what is health information? The health information is basically at the center. And for lack of a better word, and using a sort of a communications approach, it's content. It's content. It's content that we deliver. It's content that delivers various messages, and it could be for education, for prevention, diagnosis, and/or treatment. So this is content. So whether you're doing telemedicine basically being diagnostic services, telediagnosis, where you're at one end of the world and your physician's on the other end of the world, and you're talking to each other via Skype or web conferencing and so on. That is practicing medicine. So it's evolved from just just being able to send a message or try to teach a health promotion or a behavior change or just a message about healthy eating or vaccinations to really a bilateral interaction. So that essentially just sort of closes the loop and kind of frames the health information content on its own. And essentially the thing that complicates our lives is the convergence of all these media. So video into computers and audio into computers and radio online and TV online and Netflix, and all these things converge with each other that complicate our life even more. And then you add personal devices, and as you'll see at the close of this talk, you're now adding some other elements like the Fit bracelet and self-diagnosis and so on. So it really is a complicated landscape that we need to deal with. But the bottom line is that we still need to have some basic approaches and basic understanding of who we're talking to, how we're using the vehicles, understand that they're converging, the YouTube and all these things, and I'm probably missing a few other things that are coming out now. But very often, a lot of people say, well, we got to get social media. We got to get social media. Let's do social media. We need to have a Twitter account. We need to have a Facebook account. And many companies failed dramatically when they started doing that because they didn't really understand it. It was just a bandwagon. Yeah, we'll have a little Twitter bird on our ad, and that's it. There's only a few companies that really succeeded. American Express being one of them, for example. They were very successful with Facebook. But not many companies have done it. Now, more and more it's happening, but when they first started out, everybody was trying to do it. So the bottom line is that, again, you need to have a sort of a thoughtful approach into how you're going to be using the new media, which you can actually backfire in certain situations if you don't know how to handle the responses that your followers give and so on. So I think the bottom line is that we need to be aware that there's a convergence. And there's a new vehicles, again, nothing new to you. It's on-demand technology, wireless applications, smartphones, and all of these things. And these now have created an even bigger opportunity for us to converge and provide us a terrain or a platform for health communications thinking and approach. And as you'll see, these are very, very easy for us, not easy for us to do, but they're not out of reach for us to do. And that's one of the advantages of new technologies. So I want to spend a bit of time. I talked a bit about the sort of that backbone structure of how the healthcare interface actually interfaces itself with communications. And so I'm going to talk a bit about now the audience, because we need to talk about audience characteristics, because that's quite important in anything that you do, whether you're advertising, whether you're doing a social media campaign or a social marketing campaign or a campaign for vaccinations and so on. You need to understand your audience first and foremost. So one of the things that impressed me was essentially, this is a great book by Robert Cialdini. He's a professor at Arizona who really talks about weapons of influence, how we influence people. So, just an advertising class, this is quite applicable to my domain in terms of a health messaging, but it's also applicable to sales and marketing of whatever you want. And so he had a couple of principles, and the first one that he had was reciprocation. So understanding the audience, also you need to understand some of the persuasive techniques. So some of the persuasive techniques, one of them is reciprocation. So what do you think we give free samples for? Studies have shown that you give free samples and gifts, people will become more loyal to whatever you're selling, whatever you're marketing. Whether you're selling a book, a car, or whatever it is, that people will reciprocate. So that's the theory of reciprocation. And for anybody who's interested, in this book, and if you can Google it, he's got some really nice synopses of the experiments that actually, these are all scientific experiments that were done that actually supported these and give examples. The next one is commitment and consistency. And again, the experiment that they did was actually asking people, are you going to vote? They did it in a public forum, and a lot of them said yes. And the ones that said yes actually voted. The ones that weren't asked, there was a lower voting rate. So essentially, if you're committed to something, if you're consistent, you will basically be more adherent to that demand. And I put age matters there because with age, you tend to be more consistent and more difficult to convince to change. So we need to know that. So one of the how we frame the elderly in terms of behavior change is trying to recognize that they're consistent and recognize the kind of old ways of doing things, but give them new evidence in a proactive way, in a positive way that will help them, overcome that consistency that sort of keeps them behind in terms of, even getting a television set or getting a computer. Social proof. This is actually a neat one as well. This is one that is one of influence, sort of peer influence. And the study that they did was on laugh tracks. Obviously, what do you think they use laugh tracks for? They put laugh tracks so people can laugh. Other examples were, there was one where they were playing cards in a room. It was all set up, and they were playing cards in a room, and there was a guy fixing a light post, and he fell off. And the victim, the victim of the experiment, the others were all actors. The victim sort of was looking around. Nobody would get up to help the guy, so he didn't either. So that's social proof. That's really looking at people around you to influence you. So again, that's another mechanism with which people are influenced and could be persuaded one way or another. Liking is actually very, very obvious to many of us. You actually will you'll identify more with somebody that's more like you or more similar to you. So studies were done on people who had names that reminded you of yourself or that were similar. Even something as random as having the same name, like I said, can increase your prospects for sales or behavior change or whatever your end goal is in this situation. Authority is another one. This is an interesting one. They did a study again, they had one experimental victim, I call them, and they had the rest were all actors. And one of the guys was in a lab coat, and they were doing experiments on if they got something wrong, you press a button, they'd be shocked. But it was fake, they wouldn't shock, but they would pretend they were being shocked. When the guy was wearing a white coat, the people tended to shock them more and not stop because they feared that the guy authority would tell them to continue shocking them. But when they had somebody else not wearing a white coat, they would sort of give in to the guy saying, "It hurts, it hurts." I know these sort of sound barbaric, but they were pretending. It wasn't a real thing. But just to show you that that's the authority. So the people have credibility, names, titles, those type of things play a role, and that's why you see spokespeople on TV and so on. Scarcity is another one. Again, supply and demand. So the less there is it's out there, human nature, the more we want it, right? So that's why they say, only 5 left, or 1 week left to this, or the countdown to the sale ends tonight. All of these things are made to enhance. So example of these are people going after the holiday toys. It's a frenzy for it because there's only 5 left in the store and they wait, or the people waiting overnight for the 10 or the 15 iPhones that are coming for 1,000 people waiting in line, the next morning. So those are the type of things that we're looking at in terms of scarcity. So then again, techniques, these are techniques and paradigms and approaches that can be sort of embedded in any type of marketing endeavor one wants to create. But it's important to understand these, and it's important to know your audience and try to match some of these characteristics into the message that you're trying to convey. Another one is another book. This is one of my other books that I like a lot. It talks about communication and attitudes in the 21st century by Richard Perloff, and basically he talks about attitudes, beliefs, intention, and behavior. So again, understanding the attitudes, the beliefs, the context of who you're talking to is very important. And who says it, again, is important. Again, this is, and it kind of overlaps with some of the authority and likeness, likability of some of the work that Cialdini talks about. And message factors. And I'll spend a bit of time on this because when we talk about audience characteristics, these terms sometimes may not resonate to a lot of people. So, for example, how severe is the message? You're going to die if you don't do this. Are they susceptible? The people susceptible to these messaging. The response efficacy and self-efficacy is very important, and I'll talk a bit about that. And just keep that in your mind for a second. I'll talk a bit about personality and persuasion. What aspects of an individual's character influence persuasibility? So this is where looking at the audience characteristic, if you'd like, through the lens of that the persuasion theories that I talked to you about. Interpersonal persuasion is a compliance techniques, and again, I will spend a bit of time on this because I think it's very important, and I can't underscore the importance of the audience characteristics, both in terms of the psychological, socioeconomic contexts, as well as what medium they want to use. So for example, you know, if it's a youth, you're obviously not going to put it on, you know, the daily newspaper, you know, or if it's an elderly home, you may not want to put it on Twitter. You know, it depends on the situation. But aside from that, you know, when we look at audience segmentation, and you segment your audience, and you look at the demographic profile of your audience, and you say, you know, demographics, which are typical ones: age, sex, income level, school level, language, cultural, socioeconomic context, and nuances, and the context itself. Important. I'm not saying they're not important, but we need to add self-efficacy. And self-efficacy is a concept that really is important, especially in public health when we are doing social marketing, and social marketing that, as you'll see later on, is designed to create a behavior change among a population. So when you're doing self-efficacy, when you're looking at self-efficacy, it has to do with one's sort of vision of him or herself being able to do something. So self-efficacy, so you tend to be protective. So people with high self-efficacy tend to be protective. They accept change. They want to say, yes, you know what, I'm going to stop smoking because it's not going to kill me, because I want to live. Whereas somebody who has a negative or a low self-efficacy will be negative, and essentially will say, you know what, I'm not going to quit smoking. I'm going to die anywhere. My cousin died of the smoking. I'm not going to die anywhere. Like, I can't do anything about it. So it has to do with self-empowerment, the empowerment that they feel. And unfortunately, a lot of the poor areas that we deal with, especially in my area where we have pockets of the population that are among the poorest in Canada, the self-efficacy is very low as well. Like, they've given up. They've given up. They don't think that we can do anything about it. Well, you know what? I was born here. I'm born this way. I'll die this way. And that's something that we need to take into account, because you can't start going in there and doing all these, you know, fancy commercials or multimedia messaging to a person that you know the message won't penetrate. You have to find ways to get around that barrier. So it's very important for you to understand the concept of self-efficacy. The other thing that, again, is in health, in public health, we talk about the social determinants of health. The social determinants of health have to do with what makes you healthy or unhealthy. And you know, people are shocked when I tell them that 75% of what makes you healthy or unhealthy has nothing to do with health, has nothing to do with the healthcare system, has nothing to do with biology, has nothing to do with medicine. It has to do with socioeconomic status, the social determinants of health. Where you live, how much money you make, how much school you make, how close you are to healthcare, what your social capital is, and so on. And they determine your health. Yet in Canada, and I'll plug some political stuff here, yet in Canada, 50% of our budget is an acute healthcare, whereas 75% of what makes you sick has nothing to do with healthcare. So we need to have a paradigm, a shifting paradigm of change in terms of how we focus that. And so when we're talking about social marketing, messaging, especially dealing with this type of population, we need to know their socioeconomic, where they sit in that social determinant scale. And we need to act accordingly, because just to the nature of their disadvantaged position, they're going to start off. So if you look at time one here, these are individuals. The green here is individuals who are poorer, and the blue line is the individuals who are richer. So let's say you start at time one, and already there's a knowledge gap because of education, perhaps, because of where they live, and so on, lack of social capital, or whatever you want it. There's a gap right there. So even if you educate that individual and you have the same message that says, you know, don't do this or change this habit, and then you test them, you know, 2 or 3 weeks down the line in terms of what knowledge they've obtained, and hopefully that knowledge will translate itself into behavior change or lifestyle change, depending on what you're trying to get out there. There'll still be a gap between the higher socioeconomic and the lower socioeconomic populations here. So you have to know that. So your expectation, so if you're evaluating this project or if you're selling something or whatever it is, obviously this outcome will be different than that outcome. So if you're not taking into account those nuances, you might think your project has failed, or those type of things. So again, and then you might go back and say, well, because they have the knowledge gap to begin with, maybe I shouldn't be doing the same approach to this population or this neighborhood as compared to that neighborhood. So these are things that you need to have in your mind that really, really underscore the importance of understanding who you're talking to, and what effect you're trying to change, and what effect you're trying to implement, and what change you're trying to effect. But at the same time, you need to be able to understand that you may have to have different approaches for these different populations. So one size does not fit all. That's really the message. So social marketing, so there's a classic definition of social marketing, which is really defined as a process of designing, implementing, and controlling programs to increase acceptability of a pro-social idea among population segments of consumers, whatever that means. That means that you're trying to change people's minds on a large scale. That's what you're trying to do. And so when you're doing this, you need to take into, again, consideration of a population. So this is a population change. And examples of that would be increasing rates of eating vegetables, trying to decrease obesity outcomes and so on. And again, there's spectrums of different campaigns that we're using, and I'll give you some examples a bit later. So this is a more sort of a more recent definition of social marketing, and this was done by the CDC, the Centers for Disease Control, United States. And essentially, they describe social marketing as the application of commercial marketing technologies to the analysis, planning, execution, and evaluation of programs designed to influence voluntary behavior of target audiences in order to improve their personal welfare and that of society. That's a big mouthful. And again, what we're trying to do is we're trying to work through multiple, and this kind of summarizes what I've told you. You're essentially looking at the application of commercial marketing technologies and analysis to the analysis, planning, and execution. So the analysis and planning has to do with the message and who you're delivering it to, understanding your audiences, and then implementing them. And then your end goal is to have some kind of a behavior change that elicits itself as better health and better wellness. That's really what we're trying to do in terms of social marketing changes. When do we use social marketing? Under what context do we use it? Again, trying to change the behavior of a large number of people, obviously, trying to change people's behavior permanently or over a long period of time. And this is again some of the challenges and differences and nuances. So for example, if you're advertising to sell product X, you can know at the end of the year how many products you've sold. Great. So you're able to do that, and measure it. So you know that you've invested your money and you've got back, we sold 1 million records or 1 million whatever it is. With the social marketing, you can't necessarily measure it over a year. You really can't. It's over a long period of time. So if you want to elicit smoking rates, decrease smoking rates, if you want to decrease cancer rates, if you want to decrease or increase physical activity among young kids, or if you want to, those type of things, those are long-term outcomes, which are challenging to us because A, we are funded by the government. We're actually a government agency, and the government wants to see money for value for money. So they say, okay, we're investing $100,000 today. What are you getting in return? Well, you may not get $100,000 worth in return right away, but you will get $700,000 in return 10 years down the line because we know that it's a 1 in 7 return. So that's why social marketing programs are done, because they know that the return is so high. But the work you need to be patient. You need to understand you just can't elicit that change over a 6-month period. Again, it all depends on what you're trying to do. But you're trying to create big changes at a population scale that are measurable over years, not months. Whereas if you're advertising a product or service, or you have a concert you want to promote, whoever shows up has listened to your message and you're successful. So it's a real different approach. You're also targeting a voluntary behavior change, and this is voluntary, where we're trying to tell people not to smoke or to stop smoking and so on. And this is where public health has a bit of a protection and enforcement aspect to it. So sometimes social marketing has to go together with enforcement. So in Ontario, we have Smoke-Free Ontario, which is the law that prohibits the sale of cigarettes to young people, that prohibits now smoking in public places, that prohibits smoking on TV screen and TV programs, that will, as of January 2016, prohibit e-cigarette smoking in public places, and so on. So we need to do both in certain situations. So sometimes, depending on what you want to change, you may have to elicit a combination, and that's what public health is. And then there are ethical questions and so on. But you might have to couple the social marketing with perhaps a layer of enforcement, or a layer of punishing somebody, or a layer of penalizing somebody when they don't do it, so that which we get now. So if somebody sells to a minor, they get fined. And if they sell over a 5-year period twice, they lose their ability to sell cigarettes for a year. So those are some of the things that we're doing at the level to control it. But then again, we're working obviously and that's sort of an instantaneous thing. And then we're working over a long term with trying to get kids not to smoke, or trying to get smokers to quit. So again, those are the nuances that we need to talk about. And obviously, we want to use an audience-focused approach. So in terms of social marketing campaign, there are essentially 5 stages that we look at. And again, this is where all of I've talked to you about culminates. So it's a lot of thinking and a lot of background work before you start planning. So you need to plan, you look at the theory, look at communication analysis, implementation, and evaluation and reorientation. And that's the important part. So let's talk about stage 1, which is the planning. And obviously, you need to plan. You need to have your campaign goal. So what's the outcome of this campaign? What behavior change do you want? And again, there's differences. When we do programs, at our health unit or across Canada or with other health units or other agencies, it depends on what you're trying to do. We can have, a marketing campaign that just elicits people to vaccinate. So for flu season, for example, you're hearing all the stuff on the radio and internet and so on, and the apps that we have. And that's sort of that's a very, limited campaign. We want it once a year, and that's it. So that's different. But that's a different focus and a different implication and a different type of outcome that you're going to want. You want to, what do you want to do? You want to create or change cognitions. You want to, if somebody is sort of, new to or innocent to the messaging, or doesn't know that this causes that, is that what you want to focus on? Or is it that they know that it's bad for them, you want to change it? So those are the things that you need to take into account when you're doing it. And then your target choice, obviously, is it the attitude or the behavior, or both? Sometimes you need to change the attitude before you change the behavior, before it translates into real lifestyle change. So again, those are the nuances of what you want to do when you're planning. The theory, obviously, using theory-specific strategies, behavioral theories, and again, this is where we come with effective approaches, cognitive models, persuasive models, and so on. We're looking at commercial marketing, association or exposure, all of these things, and persuasive metaphors. So that's the theoretical part that I talked to you about that has to be implemented into the contextually appropriate framework with which you're going to move forward. In terms of stage 3, it's the communication analysis. And again, this really goes down to what I talked to you about, the audience analysis and segmentation. And don't forget, it doesn't just mean how old, where they live, and so on. It also means some of the psychological and sociological implications or profiles that will either make or break a campaign, frankly. Those little nuances can actually make a big difference. Is the research done to one technique versus another? The channel and medium selection analysis, and this is where it comes in terms of audiences, what type of audience you have, and how you're going to elicit that message. Again, age and so on. Apply a message to context. So, is smoking Is it bad breath or COPD? How are you going to threaten people? Maybe a younger individual may not care about COPD, chronic obstructive lung disease or emphysema, as a result of smoking, but they may care that they have bad breath, they can't get dates or whatever. So those are the things that you're going to look at. So you're going to sell it differently, right, to different audiences. And then you could do pre-test or focus groups and see what works best. And we tend not to do them because they cost a lot of money and take a lot of time. So sometimes it's guesswork that we need to do, and we don't have big budgets sometimes. So, but that's sort of a theoretical approach to it. Stage 4 is implementation. And from the marketing point of view, the 4 Ps actually are product, price, placement, and promotion. So, whether you're talking about selling cars or selling boats or selling toys, it's kind of the same thing. But if you sort of break it down to implementing a social marketing strategy or a message of behavior change or attitude change or both, your product, is it a pro-social product? Is it you want to just promote seatbelt use? You want to give posters out? Those are the type of things. Your price. What is the price of the campaign? What is it going to cost us? And what are we going to get in terms of social and psychological benefits? And again, a cost-benefit analysis. Placement. Where are you going to place it? Is it an interactive media and so on? And promotion obviously involves the persuasion and implementation in a campaign setting. And then finally, and this is actually important for us, because we have to prove that what we do is cost-effective, has made a difference, and again, these are some of the challenges. And essentially, you want to measure your outcome, and it's complex. Like, what do you measure? And I'll give you some examples of the differences that I'm interested in. And it depends who was doing the evaluation, and I'll go back to that. So it's individual versus population effect. And evaluation is critical, although it's an art, not a science. And what are you measuring? So let me give you a context. HPV vaccine is called, the company that makes it is Merck Frost. Merck Frost promotes Gardasil. You've seen it on TV for young women. Now it's available for men. So when they do a campaign, what do they want to see? Sales of vaccine uptake. What do I want to see? I want to see decreases of HPV disease. So we're assessing the same material, the same product, but we want to see different things. So it's important to know that. So, and then some of the things that we're challenged with is we want to decrease BMIs among children in grade 7, for example, of which in my area about 30 to 40% have high BMIs. And so what do you do there? When do you measure it? What's your end game? So we have the government breathing down our necks saying, well, show us that you've done something or show us that it works. So we need to look at measurements, sort of outcomes and outputs. Those are two different things. So an outcome is essentially BMI scores every year, year down the line. An output is the amount of exercise or the amount of behavior change that we elicit, or the amount of lectures that we give to the class, and so on. That's an output. They're two different things. So you need to know what your actually outcome is, or what your output is, and you need to know who is looking. So, from the government's point of view, they want to have cost effectiveness. If you're marketing a product, you want to know if it's sold. We're quote unquote, when we do vaccine, essentially when we're promoting vaccines, we're promoting products as well, but we're promoting it because we want to decrease disease. We don't want measles to happen. We don't want pertussis to happen, and so on. Whereas, the companies that are selling it are looking at another thing. So it's very important to understand that evaluation really depends on who's doing the evaluating and what your outcome is, and is there a strict outcome? And like I said, at the end of the year, we evaluate our flu uptake. Very good, easy to do. We just measure the number of people that took the vaccine. If we want to do another behavior change, smoking, that may not be as easy to do. Over a 4 or 5 year period, we might see that rates change, but not in a 3-month period. So, the flu vaccine, or when we go into the schools right now, we give hepatitis vaccines to grade 7s. That's easy for us to know. Who signed the consent, who got the vaccine, percentage, and that's it. It's measured. So it worked or didn't work, whatever we promoted that year. So again, it's a contextual. From our point of view, yes, we actually gave 100,000 vaccines this year. That's great. But did we reduce the disease or hepatitis rates? Again, an outcome versus output. So it's really important to understand the measuring and what you're measuring. So again, I've talked about this before. I want to talk a bit about a practical approach. Again, I can't emphasize the fact that we need to adapt our messaging to the audience and the way we deliver it. And so our challenge really has to do with the audience changes, and they're changing. And the audience evolution is changing. 5 years ago, we have a surveillance department and statistics department in my health unit. They gave me a sort of a sheet, percentage of who uses what media, what age group. It's useless today. Every year you need to do that. Because now what we're seeing is, I would never think about doing an online program for elderly, whereas now that's the fastest growing of the segment of the population that's increasing their internet use. Facebook and so on. So it tends to be sort of the older using Facebook and the younger using Twitter, So we kind of segment it that way. So those are changing, and they're changing all the time. So an approach that we used 5 years ago is not going to work today, or we have to modify it. And then on top of that, you have your technological considerations in terms of how you produce and what you produce. And there are challenges as well. We are fortunate enough in our health unit to be able to produce these things on our own in a cost-effective way. And that's why we have an in-house facility. But in a lot of situations, and back when we started out, this is really old, but this is millions of dollars of equipment here. It looks archaic to you, but it's millions of dollars. Like each of these machines is $100,000. This machine here is a Betacam machine. It's $115,000 back in those days. So you can see how all that stuff cost. Now, and that's why I bring this up here, because I want to contrast it. And this is our studio in the health unit in Cornwall. There's an Avid system, very simple. There's a sound booth beside it. It cost us $500 to build the room, and the equipment cost us a couple $1,000, and there's software and so on. And we're able to be very cost effective. So what I'm doing is I'm using this to encourage other health units to do it as well, because it's not very difficult to do, provided you understand your messaging and you have some people that could do the productions and be able to use and apply it to the appropriate media, YouTube, and so on. So one of the approaches that I sort of like, a term that I've coined is called MADE, the MADE approach. And essentially what the MADE approach is kind of a breakdown of a summary of a lot of the concepts and theoretical analyses and theoretical potentials in terms of persuasive technology, implementing the persuasive science into technology, into our messaging and for public health. But you can kind of see that you can kind of do it for not only within public health, but others, more broader social marketing trends or changes. So essentially, it's very simple. M is for message. It's very simple. What is your message? What do you want to do? What's your outcome? A is your audience. Who's your audience? And again, when I talk about audience, it seems like one word here, but it really should be flashing in your minds all of the slides that I brought up in terms of self-efficacy, socioeconomic status, attitudes, and so on. Delivery channel, how are you going to deliver it? And again, looking at all the technological advances and all the technology that's there, what your segment of the population that you're targeting uses the most, what's the most effective way of doing it, cost effectiveness and so on, and obviously evaluation. That's kind of built in. So it's a very simple sort of four-letter acronym. And this is some examples that we've done at our health unit. This is our website. And again, we're trying to use this. This is an app we've developed, Immunize Canada, and we're promoting it on our website. And the app essentially tracks people's vaccination records. And eventually it could be transferred to a physician's office, to our office, and we monitor it. So this is like one of the ways that we're trying to work with other partners. This is our Multimedia Resource Center, which again, we made available. And what we've done in Ontario is we've actually, we are the hub for French productions as well. So all of Ontario health units use our productions, the French productions, because again, we're sharing it. And again, this is sort of what we do. We have hundreds of videos that we're playing. And this, again, and just to contrast it, this is something called MEMAG.ca, and yes, it's done by the health unit. We produce this. and it doesn't look like it, right? So we don't say anywhere we're a health unit. And this is more for adolescents and again, messaging in terms of sexual health, drugs, alcohol, smoking, and so on, tattooing, and so on. We put it in there. And so you can see it's a different approach to that. This is examples again. This is again audience specific. This was a video that we did, which is called ROI. It's actually called Return of Investment. And it was actually played at Parliament about a year and a half ago by the Canadian Public Health Association. That actually was just a little cartoon about for every dollar you invest, how much it saves. So essentially it was a political message to Parliament on what, investing, for example, in $1 in tobacco prevention, saves you $20 in future healthcare costs. And we had this for all kinds of things. We had it for water, for vaccinations, for child development, and so on. This is another one that we did, again, in collaboration. This is Public Health Agency of Canada, and the video work that we did for Immunization Canada, Public Health Agency of Canada, in support of World Immunization Day. And again, they came to us because we had the cost-effective way of doing it, so we shared it with them. And I think that's the bottom line, that we need to collaborate with others to create it. This is work that we did. Again, another example of collaboration. And one of the things that we do in terms of practical approach is, as you noticed, we've done a lot of this in partnerships. And when I talked to you at the beginning, I said to you that public health is something that we do collectively as partners to be able to work together. And this was a training, a whole training session for pediatricians with the Canadian Pediatric Society that we created that actually elicited special history from the physicians to ask about healthy living, active living. Traditionally, physicians, I'm a pediatrician, I trained as a pediatrician, we didn't really have a habit of asking how much exercise your child get a day, healthy living and all those things. So this has made a big difference actually among pediatricians now. The uptake has been tremendous, and this has been online and shared on YouTube and so on. And so again, our target here was physicians. So again, we have to taper the message, from the public to physicians to politicians. So what I showed you 3 examples that were tailored to different audiences. This is another one. This is an interesting one. This was the chief of police of Cornwall came to me about 4 years ago and said we had 7 deaths related to OxyContin in Cornwall in the last year. And we needed to put an OxyContin task force together, and then we created a task force that worked with Deb Matthews, who then changed, we sent a letter and we worked with them and with the Royal College of Physicians to better track narcotic prescriptions. And one of the things that came up was teenagers were stealing old medications from their grandparents' medicine cabinets, and so on. And so and we didn't want them to throw away their used medication down the toilet or put it in the garbage or keep it at home for risk of being broken in. A lot of the break-ins were due to this, pharmacy break-ins and so on. And so we created a MediDrop. We created an actual program that we took mailboxes, converted them, painted them blue, and put them in a hospital and put them in the police stations. And they're 24-hour security, and people can drop the medication on 24/7. This is the only one in Canada. We were the first ones that have done this now, 24/7. Ontario does it, but every year, once a year. We do it on a daily basis with the police. So again, this was again in response to the need of the community, and it came to us, but we reacted to this. So this is a program that was done in conjunction with the police, with the hospitals, other agencies, and at the same time provided a service. So we embedded a service and a little video talking about what happens if you don't properly dispose of the medication. But Triple P is another one. Triple P is a program for parents to help them be more positive parents, for lack of a better word. It really teaches them basics of parenting. This is an evidence-based program out of Australia that requires every health care provider, every person that engages with parents to speak the same language, so to speak, in terms of parenting, same approach in terms of discipline and so on. And we did this because we had our area, especially in eastern parts of our area, Cornwall and Hawkesbury, very high rates of kids not being ready to go to school. Related to single mothers, who make 20% of our population. 20% of our families in our area are single mothers, and they're among the poorest in Canada, and their kids are not ready to go to school, and obviously they need the support. So we provided the support, and again, worked with 40 other agencies to be able to provide this program across Ontario and provide the collateral communications material that went with it. Again, working in partnerships. So it's not just, we're doing this really to help and reach out. So these are examples of how we do that. And then in terms of concluding thoughts, what I wanted to, again, hone in on is that the theories, the campaigns, technology, all the fancy stuff shouldn't replace, our human communications, one-on-one communications that we do. And again, I go back to the original health communications wheel, and I stress this part of the communications wheel is still important, still relevant today. Sometimes you need to have that one-on-one contact. It may be through Skype, but it's direct, right? But it's still one-on-one. So that, I don't want people to forget that. And then this is another this is one, again, that gives you an example of how we had to modify a program. One of my colleagues is a professor of epidemiology at the University of Montreal, and he works with the Cameroonian government. He's actually Cameroonian, and works with the Cameroonian government, and approached me and said, can you create a program for us for sensitizing safe sex practices in teenagers, because they have very high rates of HIV in Cameroon, and can you do that? And I said, sure. Well, I have a video. I have that. He goes, well, you don't understand. There's no electricity there. You can't even. So I said, we'll do an audio cassette, an audio version of it. We don't have. They don't have audio cassettes there. So obviously we can't do it online. So what we did is we actually created a series of stick diagrams with a small sort of script that we taught local tribal nurses and mothers that would go around, from door to door and teach them about this. So we got the message, we got the message out, but it was contextually, brought down to the level that they could do, both contextually, linguistically, but also technologically. We had to do it that way. So this gives you the understanding and sort of the concept of the wide spectrum of variability that you'll see among your audiences, among their self-efficacy, their psychological persuasive habits, their context, their culture, their demographics, mixed in with their ability to use technology or lack thereof. And we got to react to both. I couldn't say, well, forget about it, we're not going to do it because they don't have videos or video players, or they don't have internet. We needed to adapt. So this is, I keep it there because it really sort of brings it down to, one person infects two, and so on and so on. We use that, and it was quite effective actually. The United Nations supported this. The United Nations People Fund supported that effort. So the final slide, actually the second to final slide, now just sort of recapitulates the complexity with which we're dealing with. We got the internet, source of Dr. Google, and right or wrong, and sort of pseudo ads, and people claiming that this product is better than another, and so on. We've got data security, privacy from our point of view, because we're interacting with parents and with caregivers, or back and forth. It's important for us. We've got the apps that are developing all over the place. I showed you the app, and millions of apps that are out there. Technological advancements, diagnostic devices, self-diagnosis, social media. It's all being wrapped around the patient now. And it's making it so complex for us to be able to understand that complex interlacing of all these emerging technologies. And they're not like static. They're moving targets, right? They're moving because they're evolving and evolving and evolving. Like, 5 years ago, we didn't have social media, let's say, to the prominence that we have today. We didn't have those fit bracelets, more and more, and all these apps, self-diagnostic apps, home care apps, and so on. So even more so, we're gonna look at technological advances that will affect the way we communicate and interact with the populations that we serve. So this is a challenge to us, and unless we keep up with the times, we're going to be left behind. So again, in the context of a social marketing program, we need to take this into account as well, because this will impinge on it. If you're doing a social marketing program, they're already plugged into something, or they're convinced, or they have one way of doing it, or you can't tip it, or maybe you can tap into that, it'll be more cost-effective for you. You've got to be aware. You've got to be aware of the landscape of the technologies that they use, of course, understanding their sort of audience behavior. And sort of one of the paradoxes that we see in public health is, TVs are getting thinner, but the population is getting wider. And as you know, 2 hours a day or more of screen time is associated with increasing rates of BMI and obesity. So that's kind of a paradox that we're doing. We're using the technology, but then we're telling people don't watch TV for more than 2 hours a day, or don't go behind the screen. So it's kind of a paradox in between. And that's it for now, for me.